Welcome. This is Eric Goff-LaRude, and welcome to the first webinar of 2013 for the Hospital Screening, Brief Intervention, and Referral to Treatment Initiative series of webinars that will be taking place monthly through the remainder of the calendar year. The Hospital SBIRT initiative is an activity of the Center for Substance Abuse Treatment's National SBIRT Addiction Technology Transfer Center program. The particular focus for today's call and for the series of webinars will be to improve access to care for people with substance use disorders who are seeking treatment in hospitals or other healthcare settings. Of the 2.5 million patients admitted annually with substance use disorders into the nation's hospitals, fewer than half are asked about their substance use, according to NIH. Less than 1 in 20 of the 1.5 million patients admitted for trauma caused by risky substance use have any notation in their medical records that substance use was assessed. Hospitals and healthcare settings miss many opportunities to treat patients for these very treatable illnesses. Clinicians receive little training about substance use assessment or treatment in medical school or in their health professional training, and they're not trained in brief intervention techniques and are often unaware of community treatment resources and medications that are available to treat addictions. Medical and hospital billing departments are unfamiliar with the new screening brief intervention billing codes, limiting reimbursement for these services. The Joint Commission for Accreditation of Healthcare Organizations has developed a set of performance measures. If the Joint Commission were to mandate to the nation's 5,000 hospitals to routinely screen and treat patients' substance use problems, very few could comply. But if done, screening and brief intervention could cut re-injury and rehospitalization and save billions in treatment dollars. This series of training programs, or webinars, is part of a broader effort which we encourage you to become a part of if you're not already. This webinar and the PowerPoints that will be used today are already posted up on the Hospital SBIRT website, and I will give you a couple of times that location. It is simply hospitalsbirt.webs, W-E-B-S.com, hospitalsbirt.webs, W-E-B-S.com. And if you look on the scroll bars at the top under webinars, this webinar, the PowerPoints, are already in there as the last set of PowerPoints. We encourage you to sign up and join us. At the present time, we are recording the presentations, and we will be posting the audio recording as soon as it is available, which should be within a day. All lines right now are muted, and if you would like to submit questions at any point, either that you're having technical issues or if you have questions of either of our presenters today, please type them into the box on the right-hand side of your screen. And at the conclusion of each of the presentations, I will either read those or we will reach out to you to have you read and ask your questions. So I would like to now move into our first presentation. We have two terrific presentations today, both of which have shown success in having an impact in healthcare settings when substance use is identified and appropriately cared for as integrated services in the care delivery system. The first presentation will be from Ray Tamasi, who is the CEO President of Gosnold at Cape Cod. He oversees Gosnold's inpatient, residential, and outpatient programs that comprise the Cape's largest behavioral health treatment organization, with locations from Falmouth to Provincetown. He has presented on addiction topics both locally and nationally. Gosnold employs more than 375 professional and support staff. Last year, the organization admitted more than 4,500 individuals to its inpatient programs and provided 66,000 counseling sessions in its outpatient clinics. Mr. Tamasi will be joined in the presentation by the nurse liaison who has provided much of the day-to-day identification, intervention, and care management services that will be the focus of today's presentation. So let me turn it over to the two of you. And Ray, please share with us the exciting project that you have. And please, for any of you who have questions, type them into the bar at the right, and we'll have them answered at the conclusion of his talk.
Well, thanks very much, Eric, and very pleased to be joining you today and talking about this project and about Nancy's later. Both very, I think, important things for us to share and to get feedback on, actually. So this is a project, as the title here indicates, that really had two goals. One was to ultimately improve outcomes, but it started out really as a project to try to improve medical staff perceptions in a general hospital. And it's a project that we've began about 2 years ago, and I think what we'll learn today is, I hope, helpful to folks who are out there. So I'm trying to get this baby to advance so I don't just talk about the title. Okay. I'm not able, there we go. So I think there's a little delay on the advance. So there's a couple of things that we want to try to do today. I think we have an awful lot to give as addiction specialists, and I think we may have historically underestimated the value of that expertise to mainstream healthcare. So I hope that part of what we are able to get across today is that we are very relevant, even more relevant today in the way healthcare is sort of reframing, reorganizing itself. The second point here is kind of obvious, but surprisingly, certainly to us, is that the interventions at the hospital level certainly do improve outcomes. We saw some very dramatic improvements in our project. We had an element to this that I think was quite unique, and it turned out to be a very powerful and effective way to have hospital personnel, particularly nurses, think about addiction patients and perceive addiction patients. So we'll talk about that. It's a variation off a work-based learning approach. And finally, the obvious thing about how collaborations between entities ultimately leads not only to integration but to better care. So just by virtue of what we all know, 25 to 30% of hospital admissions are for alcohol-related conditions. It's a number that many of us have known for a long time, but it has not resonated with hospital administrators and management relative to doing something differently in the hospital. Certainly, we are on a campus about a minute and a half from the main hospital, although we're not part of the hospital system, and we see just from the patients who they refer to us that withdrawal is certainly undertreated, in some cases not treated at all. And as a consequence of that, and what we found in our project is that patients in certain diagnostic codes that relate to alcohol-related conditions have longer lengths of stay in the hospital and encounter many more medical complications. And from the interest of administrators, another thing that I believe they know but have not really paid an awful lot of attention to is that ends up being a costlier hospital stay, and certainly will be even more costly in an environment when you're paid for not so much for services that you provide, but for taking care of populations in quasi-capitated arrangements. So we saw a great opportunity for us in this project, and actually it has been leveraged, and I'll say a little bit about this at the end, into doing other things that are behavioral health interventions into chronic conditions, because the emphasis going forward certainly is going to be on how can we better manage patients with chronic conditions in an effort to bring down costs. I think the new arrangements that are being created are bringing attention to administrators also that addiction and mental health illnesses are a significant portion of those costs and are not really well managed because primary care docs are not equipped to handle them, and we can make a much greater impact. What we've seen in the last 6 or 8 months is we've migrated this concept into primary care practices, is that the docs have been very, very receptive to having behavioral health clinicians in their offices intervening with patients who are both affected by substances or mental illness, but also patients that are dealing with chronic conditions that they are not able to manage independently. So the learning out of this hospital project has reaped benefits for us in other areas. Now, the venue within which all of this happened is Falmouth Hospital. Falmouth is a small little community on Cape Cod, and it's a 100-bed hospital. It's on a health campus, and we're on that health campus. There's a skilled nursing facility, assisted living, VNAs, the whole ball of wax. We have a 50-bed primary care center, which was referred to as Detox, and system-wide we have about 175 beds of care at various levels. So we've been on this campus for 30 years, and even though we have by necessity a relationship, it has never been collaborative in the way that this project brought us over the last 2 years. The perceptions about addiction patients in the hospital and the perceptions about Gosnold as a treatment organization has pretty much been a place where the emergency room primarily could send those people. So it was a fairly, I think, quite common stigmatized view of addiction and addiction patients, and even though we had proximity to the hospital, there really wasn't the kind of relationship that would advance seamless patient care. So the question that we get is, so what happened after 30 years? What happened? So we took patients from the emergency room almost on demand, because the objective of the emergency room generally with addiction patients is how quickly can you get them out of there and get them somewhere else. And since we were the best show in town for that, we were the ones who were getting the calls. So the interesting thing, I think, was that it wasn't any real sophisticated event or analysis that led to the origin of this project. Normally we put these 5 things up and we ask folks to say, look, what do you think it was that changed the hospital's mind? So we're going to just leap over that consideration, because it was actually the complaint of a family in a very well articulated letter to the hospital administrator that triggered initial discussions of this event. So it didn't have anything to do with cost analysis, which you might think. It didn't have anything to do with length of stay or utilization. It didn't have anything to do with medical staff complaints. It had to do with a letter written by the daughter of a 78-year-old man who was treated in the hospital for a condition. He was an alcohol user and abuser, had never had treatment, and during the course of his hospitalization went into withdrawal. His withdrawal led to a lengthy stay in the hospital, during which time the care that he received, and more importantly, the manner in which he was treated, was sort of less than desirable. The family wrote a letter about that, and as I remember the ending of that letter, essentially it said, I'm writing this letter to let you know that no one should be treated as my father was, because he has an illness. and I hope that something comes of the time that I've taken to write this letter. And I guess to the hospital administrator's credit, she made a decision. She called me up. She said, I've got this thing I got to talk to you about. We need to figure out what to do. Can you come up with an idea? And so we began, that sort of launched the project. And we began a series of meetings that involved the hospital administrator, quality management, the quality improvement person, the director of nursing, some of the floor coordinators, and some folks from our side. And we started to lay out a plan that was designed originally really to address the attitudes of staff, because the letter and the complaint had to do with how the patient was treated and how the patient was spoken to. Some of the things that certainly most of the folks on this call are familiar with. Again, the kind of shaming and stigmatized responses to patients who have this illness. So initially our intent was to try to figure out some way to train, educate, or change the attitudes of the staff. The important thing about these early meetings is, and I think it was very important relative to the ultimate success and buy-in on the program, is that we had commitments from the top folks in the hospital. There was no wavering from this. The administrator said this is going to happen, and from that point we had very little difficulty, at least in advancing the project. And we certainly hit a few landmines along the way with individuals, but for the most part, everyone at the top line in the hospital was on board. One of the things that we wanted to do to find out whether or not this actually made a difference was we wanted to look and see what was the environment that we were going into. I mean, did we have some data that we could use as baseline, not in any real, I think, statistically significant way. We weren't doing formal research here, but we wanted to get a sense for whether the impressions that the hospital folks had were in fact true. And so we went back about 6 months. We had access through actually Margaret, who was in the hospital at the time, working in the hospital, had access to records. We got some printouts of patients admitted over the previous 6 months. We looked at certain diagnostic codes to identify patients who had conditions that were more than likely related to alcohol or alcohol abuse. And we took about a sample of 25 or 30 of those? Mm-hmm. Yeah, 25 or 30 of those. And who were they? And most importantly, how long were they staying in the hospital? So we came up with an average length of stay for those patients looked like it was close to 15 days. And the most surprising finding in that retrospective review was that half of the patients that were in this cohort ended up in the ICU, not for the condition which they were admitted to the hospital for, but for the management of advanced and complicated alcohol withdrawal. And in a word, they all went into delirium tremens. They went to the ICU. They were intubated. They were medicated with a medication called Precedex, which essentially put them into it's like a semi-coma, I guess. Mm-hmm. But and that's how they'd end up in the ICU for 5, 6, 7 days. All of these things contributed to a very negative perception that the staff had about alcohol-dependent patients. And so that was the environment that we were walking into. Our program idea encompassed generally 5 areas. There's a huge delay from the time I pushed that button, Eric, to the time the slide changes, but that's okay. The first thing was staff trainings. So we wanted to organize a number of trainings, primarily with nurses and also with physicians, but primarily with nurses because they were the ones who were in and out of the rooms. So training was part of it. It seemed clear that in order for the hospital staff to begin doing better in terms of identifying and intervening in a more timely fashion, that we'd need to support them and do consultations on the Med-Surg floor in the rooms with the nursing staff and with the supportive physicians. We also wanted to have a counseling component to it so that patients who were so identified during withdrawal might have an intervention with a counselor during their stay. We had limited resources, but we also wanted to get into the emergency room and cover the emergency room. They welcomed us with open arms. And what the thing that we added near the end of the, well, not near the end, but I guess probably after the first 2 or 3 months, after we had done a couple of trainings, we determined that we wanted to have nursing rotations at Gosnold. In other words, bring hospital nurses into Gosnold, into an acute care addiction unit, and have them experience that, be in the environment, interact with patients, because as we learned after the trainings, that simply doing a training, and we did 4.5 hour trainings, simply doing a training and educating people and helping them, talking about the neurobiology of addiction, how treatment works, and how you interact and engage with addiction patients, that really wasn't sufficient. Probably the most dramatic element of the training seminars was the family intervention piece. We have a team of interventionists, and one of the things that we did in the training was we actually conducted a little role play near the end of the training where the intervention team came in and they played out a family, sort of a dysfunctional family moment in their home, in active alcoholism, and then we actually conducted a mock intervention. That kind of hands-on observational type experience was very, very moving for the nurses, and I think it was one of the more effective pieces of the training. But you might want to say something, Peg, about the information that we transmitted to nurses and what your observations are about what they came in with as a knowledge base before we even began the trainings.
Yes. The nurses were effective hospital nurses in treating patients with all kinds of disorders, but they weren't as familiar with treating alcohol withdrawal, and they needed training on what withdrawal was and how to treat it better. A lot of patients were being under-medicated, so they were progressing on to have more complications. And so in the training, we talked about the neurobiology, but I went through all kinds of addiction protocols and taught them how to assess patients in terms of, what the symptoms were and what medications to use. And that was very, very helpful. They learned very quickly, and they understood that they could make a difference in terms of the patient's withdrawal. That was during the training. Do you want me to talk about when they came over, or you want to wait?
No, we'll do that in a second. One of the things that I did want to stress, and that this thing about language makes a difference. We've taken great pains here at Gosnold in all of our programs, and we're constantly on it about the language of addiction. And by that I mean that we use terms in our field that are not always familiar to folks in other medical areas, and nor do they conjure up the most pleasant sort of thoughts about the patients. And some of the things that we did in the hospital, we aimed to help them understand that what we were talking about, we always went in with a chronic disease management kind of an idea, and what we had talked about was trying to help patients get into remission. Got good audio? Can you hear me? There you go. We talk about patients getting into remission. We talk about recurrence of acuity instead of the word relapse. And we talked about what are we really trying to do with chronic disease patients, and that is extend periods of remission, shorten periods of acuity, and improve functioning during remission. And we'd always add, just as we do with patients who have other chronic conditions. And so it's beginning to sort of move away from some of the more pejorative references to addiction and avoiding terms like addict and alcoholic and referring to the individual as a patient with an illness and describing that illness in terms that are more familiar to medical staff, I think really had an impact on and just getting them sort of moving their frame of reference a little bit away from the more stigmatized view and to the idea that these actually are patients who have an illness and they can get better, and thinking about what we use, and we still use that word relapse, but thinking about regression really as part of what often happens with patients with other chronic conditions, and we'd ask, what do you do with those patients when they have periods of regression? They say, well, we bring them back and we try to sort of reformulate a plan of care, and we try to restabilize them, and so and I say that's what we're trying to do with addiction patients also. There is no such thing as going to a 5 or 6 day treatment experience and walking away, and if you ever drink again, then somehow or another either treatment is not worth it, or there's something wrong with the patient, and the blame is placed upon the patient. So those things began to make a difference, and we stress that now. Actually, we stress it in our own organization, because our own organization, we have folks, as tradition would have it, who still use that kind of terminology. Concurrent with the nursing training, we also did physician trainings. We've done a number of them over there. The first one that we did, I think we had 6 docs. We were doing neurobiology of addiction, how to treat withdrawal. The last 2 that we did 2 this past summer, one on opiate prescribing and one on med-assisted treatment and the opiate addiction, and the entire room was filled. So, I mean, that speaks more. Hopefully that speaks to the success of this program. It also speaks to the way prescription opiate pain medication have invaded the entire medical community, and they're very nervous about how they're providing that treatment. So these have been very successful. The hospital uses hospitalists. All of the hospitalists are on board. All of the hospitalists have access to the service and the consultation line. And so the trainings have been ongoing. We've trained over 150 nurses. We've done it in other hospitals now, and actually we've done too many. We're bored with the trainings. We need to do something different. The other big part of this, probably the central part of this, of course, is the actual consultation line. We created a consultation line that was made available for any nurse or any physician to call when they believe they had a patient who may be in alcohol distress, or where there were indicators that alcohol withdrawal might occur. And you may want to add on here, Peg, to this one. One of the things was about screening, how the nurses were screening patients and how they were asking questions during their H&Ps, really sort of blowing by the drinking question. We helped, actually Peg wrote some other scripts that helped them do that a bit more carefully, and if you want to say some things about that. And then began to do on-floor teaching with them, both relative to asking the question, but then perhaps more importantly, the actual assessment of the patient for alcohol withdrawal needs. So.
Yes, this was a crucial part of the project. I would check the consultation line every day, and sometimes there'd be 6 or 7 consults. Nurses, doctors, everybody actually called. Sometimes it was a patient already in withdrawal that they wanted to make sure they were medicating correctly. Other times it was someone who wasn't there for alcohol withdrawal, but they were suspecting something was going on. They were coming in for surgery and not really saying that they drank alcohol, and then they started having symptoms of withdrawal. So they weren't really sure what this was. So I spent a lot of time on the units assessing patients and teaching nurses on the spot in terms of going through the withdrawal protocol and showing them how to look for symptoms. This was probably, the largest time consumer that I had as I was in the hospital doing this. We ended up, touching base with families during this and referring people to treatment. But what I noticed right away was that the skills were better in terms of taking care of patients with this. And they would call me much more often once we got going, and there really were, there was just such an improvement in the care of patients in withdrawal. The protocol that we used pretty much was, we used Ativan or Valium in the hospital. We had IV access, so it was easy to use those two. And Ativan, for the most part, was it. I think the problem I found in the beginning was that they were under-medicating. They were scoring on the low side, not recognizing the symptoms. For example, they'd think they weren't sweating, and then I'd tell them how to feel the bed or ask the patient, did you wake up, was your bed wet? And then they could see that they really were sweating, so you'd get more of a score. But there's 7 different areas you look at, tremors, anxiety, blood pressure, pulse, sweating, and anyway, I just taught them how to assess the patients more on that. The doctors were very interested in the project. They were, they recognized that patients do go into withdrawal. There were patients sometimes that were going into delirium tremens, and they were post-op, and they had no idea that was going to happen. They were very interested in the medications, and they started calling consults after a while, so I would come up and see their patients, and it ended up being quite a collaboration. They were, then they went to the doctor trainings, but they realized that they know something about withdrawal, but that they weren't experts at it, and they were, more than interested in getting help. The nurses' attitudes, and actually everybody's attitudes, because they didn't really know how to take care of the patients in withdrawal, were that these patients are difficult. They, they end up having seizures, that kind of thing. And so what happened is they were able to medicate them better and take care of them better as their attitudes changed. They really understood that it was a chronic illness and that there was something they could help the patients with. We had, examples of, yes, there's an example of one nurse who, really had not much experience with it, and we had a patient go into delirium tremens, and it really kind of scared her. And afterwards I met with her, and she said, well, I don't ever want to take care of an alcohol-dependent patient again. That was horrible. And eventually, Ray will tell you about the program that we had where we brought nurses over to the Addiction Treatment Center and let them spend 2 days here going through the program with the patients and working with nurses who, specialized in addiction. And this particular nurse came over and did the training and came to me and said that, it completely changed her attitude about patients that were alcohol dependent. She said that it just changed her life in terms of how to view things. She then was taking all the patients that were in withdrawal and taking care of them, and it ended up being a very positive experience.
So that really was a core thing, and of course the objective of this was to be able to do the training and to work with the nurses so that ultimately this would be an embedded practice and that they would be able to do this better every time they had a patient who presented in this fashion. I mean, we didn't expect that we would be in the hospital doing this forever. Our objective was ultimately to transform the way the hospital viewed this and treated it. So the nursing piece was certainly core, but we did have a counselor, a Gosnold counselor, who did go onto the med-surg floors, generally the first encounter would be the nursing and the withdrawal management, and then we introduced a counselor to the menu. And originally, the idea was presented to patients by the nurse, who would say, you know, there's a Gosnold counselor who's available to come see you. And we found that probably 75% of the patients said, oh, no, I don't want to see the Gosnold counselor. Gosnold being associated with addiction and patients not being receptive to that. So I said to them, I said, well, why don't we drop the Gosnold piece? It's just, you know, just bring up the counselor. And so that got a little bit better. We said there's a counselor available who can come see you, and maybe half the patients said okay, the other half said I don't want to see a counselor. And then it occurred to us that when your doctor wants a consultation for a medical condition that you have, he really doesn't ask if you want to see a gastroenterologist. He just tells you that he's requested a gastroenterologist to come by and assist in the case and to come see you, and he'll be here tomorrow. And so we then decided that we were not going to ask the patient any longer. We were just going to let them know that a counselor will be stopping by in the morning to see you. He's part of the team, and 90% of the patients were fine with it. Not only were they fine with it, most of them wanted them to come back. They were very conversant and very, actually surprisingly receptive to having that counseling intervention, which was a very brief engagement. We did not do SBIRT type screenings on the floor. We did a modified assist in the emergency room, but in the floor, really motivational counseling. The counselor would talk to the nursing staff. Because it was a Gosnold counselor, he had access to all of our services, which includes everything on the continuum from detox to rehab to residential, sober, transitional living, IOP, partial hospitalization. We have the whole mess, I guess you'd say. And that access at various portals along the way was a very important element, because if a patient was receptive to specialty treatment, that counselor had free rein to get that patient into treatment almost immediately. So the access to specialty care was very important, because as all the folks on this call know, when a patient says, okay, maybe I'll go to treatment, you really need to make that happen as quickly as possible. And so the interventions that we were able to do there were at the most appropriate levels of care, because we have a wide range of services to provide. The other part of this that probably did not have as much traction as we had hoped was the family piece. We had a family counselor attached to the team, but it was very difficult to engage with the family at times when they were in the hospital. Probably the best thing that came out of this relative to the family was that there were referrals by the counselor or by the nurse liaison, PEG, to the family counselors who were able to do interventions. They're all interventionists, so there were some opportunities that arose there for patients who were initially resistant to treatment. The other thing that we were able to do, and still do every week, we now do family addiction education series in the hospital, 1 day a week, every Sunday. It's open, it's free, people can come to it, it's posted in the hospital. Our material is all over the hospital. Another reflection of how I think we've been accepted in the wider community. A smaller part of the project had to do with our emergency room presence, and it had to do more with the availability of resources, I think, than anything else. But we had a counselor in the ER a couple nights a week just to see how it worked. That's what we were really looking to do, is to test this model out. Doing screenings, intervening with every intoxicated patient that came in there, consulting with the ER staff, and most importantly, perhaps, with the emergency room, getting access to detoxification services for patients who presented in intoxicated conditions, because we do much better handling those patients than the emergency room. And because families often accompanied patients to the emergency room, we had an opportunity to engage with them too. We had 2 counselors that covered our ER. So over the course of the first 6 to 8 months, we had embedded a fairly robust, given the resources we had, a fairly robust array of services that was beginning to change how the hospital perceived and, more importantly, treated these patients. The one thing that lagged was still this business about the attitude, and I think attitude and perception and trying to root out stigmatized perceptions of addiction patients is very, very difficult. And so we weren't entirely satisfied, as we said earlier, with the ability of the training sessions that we did in the hospital, by the way, to do that. And so we came up with this idea that we would bring them over to Gosnold, because most of the nurses, there were nurses in that hospital who'd been there, what, 20 years? 20 years that had never been in our facility, and their perception about what went on here was pretty frightening, I think. I think they expected it simply to be a group of people running around screaming and yelling and us trying to tie them down. I don't know. But so we said, look, why don't we arrange for the nurses to come? And we'll set up an opportunity. We'll set up a little schedule. We got them to come not just because they were just so anxious and excited about coming, but because we also paid them a stipend to come. So we said, this is like a day of work, and you're going to do the work day at Gosnold. I think we had somewhere around 22 or 23 nurses who did rotations of 2 or 3 days. Some of them did some time in some of our other programs. We have a program for pregnant, addicted moms and moms postpartum with babies. Some of those nurses visited that site. And I think maybe it's because it was the most surprising part of this project, but to me it was one of the more powerful pieces. And you may want to speak to that since you were coordinating some of those observations.
Yeah, it was interesting. I went around the hospital to see if people were interested in going, and at first, you know, it wasn't that interesting, and then after 1 or 2 people went, then everybody heard it was a good experience and they all wanted to come. And they basically spent 2 to 3 days in the treatment center. They would observe everything that happened during the day, but they also went to every session that the patients went to. So they learned how the patients were educated about their disease, and they were right in the milieu. So they were talking to patients, getting to know them, looking at the work they were doing on themselves. And the one group that they all responded to the most was they have an hour and a half of group therapy each day, and it's a small group, and the nurses were allowed to go and observe, and that's where the patients were doing their real work, talking about their illness and its effects on their life, and every one of them found that to be an incredible thing to witness. So overall, that was the thing I think that had the most significant effect on changing their attitudes and on making the connection between the training about this is a disease and this is a neurobiology and these are the people, and so that was very valuable.
I think one of the more powerful moments there was when a nurse came out of one of the group therapy sessions and had witnessed the patient sharing, I guess, certain intimate details of their addiction, their life, and it turned out to be a patient who she had treated in the hospital about a month or 2 earlier, and when she came out of that group session, her view of that patient was a 180-degree difference. She saw, and I think it was true for all of the nurses, as they said, you know, there are a few comments here that we extracted, but for the most part, the sort of the cover comment here is we finally saw this patient as a person who's struggling with an illness and not just somebody who's trying to drive us crazy in the hospital by being resistant or by carrying on or by refusing treatment or by leaving and then coming back 3 weeks later. And I think that, I guess what it brought to us is that we know some of these things, but the gulf between what really happens and what people think happens and how they envision how patients are going to be is so different than the way it really is when they're being treated by a staff that respects them, that understands the illness, and is able to communicate to that individual that you have dignity, you have worth, we're here for you, we're here to serve you. And that is the whole service part of the reason why nurses do what they do. Kind of gets lost with addiction patients because they're very challenging, and we acknowledge that. But this face-to-face exposure, I think, was one of the most powerful parts of our project. So that kind of says a little bit about what we did. We did training, we did consultations, we did this sort of variation of works-based learning. We covered the emergency room. We had a counselor in the on the floor and a counselor, and we still do, in the emergency room. So what have we done? We've done, over the last couple of years, about 240, almost 250 consultations. And I think it's fair to say that we're not seeing every one of them. And remember, this is a 100-bed hospital, so there are a fair number of patients. The gender split is about what we see in addiction treatment, actually, 70-30. Remember, we started out really looking primarily at alcohol patients, but I think this is the case. We have also been calling for consultations on patients who are addicted to other drugs, primarily opiate medication, and that's sort of expanding our project. One of the fascinating things, of course, is that almost very few of these patients were admitted to the hospital for the treatment of alcoholism. And relative to what this slide shows you is what were those admission diagnoses. And, 35+% of the patients who we saw were admitted for a gastrointestinal disorder, whether it was pancreatitis or GI bleed or what else? Liver problems. I mean, those were... Right.
Pneumonia. I mean, they were coming in for surgery. They had infections. They were all different reasons.
We had a couple of patients who came in for knee replacements who were, which was what, about a 3-day stay? Mm-hmm. Had a 3-day stay, and they come out of post-op. They went into a withdrawal. The withdrawal got out of control. They'd end up in the emergency room, in the ICU, for 12, 15, 16 days. So we saw some of those patients who we were able to prophylactically start on a Ativan protocol and thereby prevent withdrawal. And the patient was in and out in a normal length of stay time. So the point of this, of course, is that the patients are being admitted for a range of conditions, from orthopedic conditions to GI conditions, and they are being undertreated in the hospital. So the greatest impact of this program has been in the ICU transfer rates. The sort of non-statistically significant, but in our sample, about half of the patients we looked at in our retrospective review ended up in the ICU.
In delirium tremens.
In delirium tremens, in severe conditions that required lengthy stays. We looked at the first 150 or so patients who we saw, who we analyzed in terms of data. Only 10% of those patients went to the ICU. So probably the greatest success of the program in terms of patient outcomes is that
the ones that did consults on.
So the patients that we did consults on, and again, I stress that we still have not gotten to the depths of getting every single individual, and that's something that we're working on. But we had remarkable success in limiting ICU transfer rates. The other big finding, and it sort of goes right on the heels of the ICU data, is that we had an average length of stay of about 14.5 days in our retrospective sampling. And also these retrospective reviews and the data that we mined out of those reviews were substantiated by anecdotal information from the hospital administrator and from the nursing floor coordinators. So the post-collaboration ALOS on the patients, of about 150 of these in the sample, was a little more than 6 days. I mean, it's one thing pretty much leads to another. If you do a timely intervention, if you effectively use medications to manage withdrawal, if you do the kinds of things to screen, to ask the question a little bit more detailed way, and you become adept at doing CWA scoring in an accurate way, then you're going to improve patient care and, as a consequence, length of stay. So certainly the two most dramatic outcomes for this study was a tremendous reduction in the incidence of ICU transfers and in the average length of stay for patients. And you can see this is just another way of looking at it. Patients who went to the ICU who were in our sample, as there were some patients who did go to the ICU. There were some that got missed. Average length of stay for them was 13 days. For the other folks, just about 5.5 days to get to the average of 6.2. So these were, I remember the first meeting I had with the CEO of the healthcare system, and I was telling him about this program, and he had an EVP of managed care there who was kind of dozing off as I was talking about this wonderful program until I got to to this data and to these charts where I started talking about length of stay, and he certainly woke up, and we're still talking because we're doing new things with them now. The other thing that's relevant is how quickly is the consultation request being made, and you can see that when we waited, when the nurses waited or weren't sure or missed something and didn't call for a consult for 4.5 or 5 days, then logically speaking, I guess there is a greater likelihood that the patient was going to be missed and would end up in ICU. The earlier they called, the earlier we intervened, the shorter the stay, and so an average, it was a little less than 3 days, and I think that's even gotten better now, so that we're getting consult calls even earlier than 3 days, and that's even making things better. The other big outcome of this was what happened to the patients most of the patients who go to the hospital who get treated for the condition for which they were admitted generally don't get referred to specialty care unless they're in a very acute state or they've been back in the hospital 5 or 6 or 7 times. Because we had the counselor who was intervening, because we had the nurse liaison, and because there was a heightened sensitivity to the entire issue, we saw almost a 40% rate of referral for patients who we saw in the hospital. And that's referral to specialty addiction treatment. And because we're the only game in town, that meant patients who were coming to us. So from a business perspective, we saw patients, many of whom we had never seen before. There were some patients in this cohort who had been in a Gosnold program, but most of the patients who we saw in the hospital had never been treated in any addiction, any specialty addiction program. And so that was a really important outcome, was how well we could link them to specialty services. Even those who did not, the number here says 40% got educational material, but that's probably every person. Every person got something, I think, yeah. I think this is only educational material. In other words, refused everything else, didn't want to come to treatment, but did take something with them. And there were some of those patients who we subsequently saw in a Gosnold program, sometimes a month, 2 months, or 3 months later. So the important thing there is how accessible are the services, and can you get patients to come to them when they say, yes, I'll go, because once you allow some time to go by, if addiction patients have a strange way of minimizing their need after 48 hours. So that was an important outcome also. So sort of summarize the two major findings, reduced length of stay, ICU transfers. We looked at we started to look at specific dollar numbers, and the hospital was feeding us some of that information. It's kind of complicated and very labor-intensive to get an actual number, but in speaking to the hospital financial folks, it was pretty clear to them that there was about as much as a 40% cost savings in being able to take care of the person on the med-surg floor as opposed to ICU. It's a pretty obvious outcome, really, and one that you would think would have every hospital in the area running and calling us up and asking us to come up there and make things better at their hospital, but we really have to sell this thing to folks because there's still a good deal of a lack of knowledge and a resistance. The thing about the patients, I think, and you saw many more of the patients than I did, Peg, but it was very gratifying for us that the patient who's in the hospital who's had this condition sort of exposed or spoken about actually responded very, very well. They were interested in having us talk to them. I think they were appreciative that we were in there without a judgmental or shaming type of an attitude. They were actually better in almost every area of response to hospital personnel once we kind of normalized this illness and let them know that we were with them and not making judgments about them. You know, it's very easy if in the Gosnold addiction units, every person here knows why they're here and the staff knows why they're here because that's what we do. But in the hospital, you may have a floor of 25 patients where there may be could be 4 or 5 alcohol-dependent patients on that floor, and they go to great lengths to hide that, to keep that from everyone else because they know, either because they've had a bad experience or just because it's the nature of the illness, that there are going to be judgments about them. So patients responded very well. Staff responded very well. It's all good, although we are going to encounter a couple of challenges. So we're continuing to do training. We're looking to do more in the way of extended care management, not just for those patients, but also for our own. We're really looking for super users in the hospital to add to the team because to a great extent this has been person-dependent initiative, really what I look at as a research and development project. So we're looking now to sort of spread the knowledge across a wider group of folks. We have, it says launch the program at Cape Cod Hospital. That's been a delayed launch because they've had a number of personnel changes there. Cape Cod Hospital is a 260-bed hospital, so it'll be a much more formidable project to embed this program down there. And maybe, as I mentioned in the beginning, one of the things that we've done as a result of this is begin to work in primary care practices, also community health centers, but for the purpose of this, really mainstreaming addiction and behavioral health interventions into primary care. We're in 3 or 4 large practices now and looking to do more of that as we kind of make ourselves increasingly more necessary to a new configuration of healthcare. So we're always looking for new and better ways, and I dare say there are folks out there listening to us who may have some ideas that we'd love to hear about also. We were, as I said, we were really surprised that this project, which seems kind of obvious, was not so obvious to a lot of people, and we were very gratified that we were recognized in a number of venues last year for this as an innovative project, high-quality service, and one that was producing good kind of outcomes. So all very good stuff that I hope. And there's our team, our nurse liaison in the middle, and 2 counselors there with her, and the hospital administrator who had been in that hospital for 40 years, recently retired. And in fact, the project, since her retirement, has been stalled a little bit. The new administrator is sort of not the kind of guy who is going to jump on this bandwagon quickly, but He's coming around. We have some meetings scheduled in the next 2 weeks with the Chief of Medical Staff to get back in there in earnest. We've sort of been on the back burner for the last couple of months. So in a word, what do we come out of this for other folks? What I think is really important for those of us in the behavioral health world is we've got to be around. We've got to make our presence known. Presence equates to relevance. We are relevant. We have important things to bring to the party, but we've got to be there, and we've got to be talking to our colleagues in general medical practice and help them understand that we can make a difference for them. And what we found is, even though it isn't something that seems obvious from the outset, what we found is when we began to exercise our expertise, the medical staff wanted more and recognized that they needed it and was incredibly supportive. I remember an occasion where one of the hospitalists called up and he said, "Ray," he says, those 12 and 12 books or whatever those books are that you had over here, says, we're running out of them and I want to give one of them to a patient, one of those AA books, and do you have any more of them? And so we brought a case over there. I can't remember, in my years, I can't remember a doctor in a hospital calling me up and asking me if I could bring over an AA big book that he wanted to give to a patient. So I dare say that I can't say it enough, really. We're essential. We're important in the new healthcare environment, but we've got to get out there and we've got to make our statement. And I think this kind of project is one that does. We're very happy about it, and it has reaped benefits for us, not just in terms of taking care of people and being in the right place, but also in elevating the place of addiction treatment in mainstream healthcare. And that's been very gratifying to our staff that generally is looked at as people that are over in that building up the road, and we don't know what they do, and we never want to know what they do. But now everybody wants to know what we do, and so we're looking to extend this into other areas. So that's I don't know where we are on time because you made me turn my cell phone off and I don't have a watch, but that's pretty much what I've got, Eric.
Ray, that was terrific, and Peg, thank you very much for the work and for sharing it with us. There have been a number of questions that have come up, and if any of you who are listening would like to ask a question, the most convenient way to do it is if you would type it into that question box, and then I will share it, and we'll have Ray be able and Peg to be able to answer the questions. One question that almost always comes up when we talk about doing good work, so I might as well raise it because it's sort of the top line question or bottom line question that always comes up around delivering substance use treatment is, how'd you pay for it? Where'd the money come from, and is this now, or do you expect it will become a reimbursable service, or is this charity care?
Well, this sort of speaks to the way we do. I always say that there is no R&D in addiction treatment, but the way we do R&D, the way we do research and development, is we come up with an idea, we put it together, we write it up, we go to a potential funder, we ask for a limited amount of dollars to test the idea, and then we do it. We do the idea, we keep data, we track what we're doing, and we take that data and then we go to a traditional payer source or back to another funder. So in this case, what we did is we wrote the project up. We successfully sold it to 2 small foundations that liked the idea. They gave us some of the seed money that has enabled us to run the project for almost 2 years, just about 2 years, without any other resources. So we're now at the place where we're talking to the hospital about, because one of the things that if this is such a great project for the hospital and it saves them so much money, then why isn't the hospital paying for some of it? And that's where we are now. We're working with them to come up with some way to embed some funding opportunities. And then we are also talking to our private insurance payers, our public insurance payers, showing some of this information. So the idea is that we kind of invest in these ideas, Eric. We get somebody to help us, and then if they work, then we take them to the wider audience and look for opportunities. And certainly some of the SBIRT coding will help us in some of these areas, certainly help us in the primary care practices. That's how we do it. But that's how we funded it. We actually sold it to a couple of foundations.
Now, in developing the business case to the hospital administration and in making the case to the hospital as to why it's in their interest to support the PEG and the nurse liaisons being there and providing the withdrawal service and the consultations. What have you found? What do you see as the arguments that have the greatest impact?
Well, in anticipation of a global payment system where networks of care are going to be charged with taking care of patients and keeping them healthy, I think that what we're trying to convince folks about and what they're being convinced of by looking at data a little bit more rigorously is that untreated, unchecked, unmonitored, the patients with these conditions are going to cost their system a lot of money. With relatively inexpensive interventions, extended engagement types of approaches that keep us involved with patients, and sort of like the way you'd manage any chronic condition, will in fact reap greater sort of shared savings for those systems of care than otherwise could be realized. I mean, I think that's a pretty saleable point, and certainly using some of the data that we generated out of this project should add to the convincing part of it. So I mean, a lot of this has to do with anticipating how things are going to change and how we fit into those changes.
Now, Melanie Overton has asked a question that, if I'll kind of summarize, is that we often hear from primary care and from hospitals and other healthcare providers that they're just too busy and too overwhelmed by the tasks that they have to do to be able to attend to addiction or the substance use issues. How have you found effective ways to sell SBIRT, sell substance use counseling and interventions to very busy hospitals and very busy healthcare personnel?
Well, to the hospital it was pretty easy. To the primary care docs, basically we sell it to the primary care docs by letting them know that if we, and again, the work that we're doing in primary care as our R&D project was also supported by some foundation dollars. We're telling them basically that we're going to be able to help them with patients that have historically been using a lot of their time, that have been demanding a lot of their services, either because they've got conditions that they're reporting that they're more hypochondriacal patients, they're patients who are depressed and who these PCPs are trying to manage on psychotropic medication because access to psychiatry is limited, and so they're using up and taking up a lot of their time. Now, what we've in fact found in the primary care practices, and I dare say other folks have found this too, is that we're seeing actually fewer substance interventions in the primary care practice and many more in the area of mental health and in issues like medication compliance for patients who are hypertensive or diabetic, who are cardiac patients. We've seen a number of cardiovascular patients in the primary care practice who are depressed or very anxious about their conditions, and we're helping them in that way. It's pushed us into the broader area of disease management. So I now have 2 behavioral health clinicians who we sent to receive training in how to do type 2 diabetes education and management. We have 2 such groups presently underway. One of them operating in the hospital. One of them will be operating in a community health center. And we've also moved beyond a little bit the diabetes piece to do more broad-based chronic care management using the Stanford model. We've got 2 of those groups going. So what we've learned in the primary care practices is that behavioral health interventions have relevance in a broad array of medical conditions that have behavioral implications or that require modifications to how patients take care of themselves. So the doctors love it because they can refer the patient immediately during their primary care visit. And I spoke to one of the docs in one of the practices a couple of weeks ago, and I said, Michael, I said, do you think that because you're able to turf off some of these more complicated patients that are demanding your time, that you're able to see more patients in a day? And he said, you know, I'm not sure, but I think so. And, you know, so that data part isn't being tracked that closely, I think, but the medical practices have been very, very receptive, although initially resistant, mostly from the business manager. Got the most pushback from business managers in the primary care practices. But the other folks are very, very happy to be able to have access to that right in their own place. So,
right. Well, let me ask you a question that was prompted by David Gastfriend, which is that, and perhaps this is a question for Peg, is that you mentioned using medications to assist with withdrawal and for treatment. Did you find that a reaction of the medical staff, the physicians and nurses, positive, negative? What was their reaction to the use of medications with patients who had substance use disorders?
They were open to what we had to say. They did have an alcohol withdrawal protocol that they were using, and they were open to even adjusting it on some of our recommendation. The doctors in particular were really interested in getting more information on opiate dependence. You know, they wanted to know all about Suboxone and Vivitrol, and so they were always asking me questions about that. The nurses had no problem using the medications, and once they saw how much better people did, they were just better at handling withdrawal just after learning how to do it. So very open, I would say.
So that was, so you had a positive response there.
Yes.
How did you work? How has this impacted the program that you have? The treatment and treatment referrals over from the hospital over to Gosnold, over to your services. And well, I guess one of the concerns often that we hear from hospitals and other healthcare providers is if we identify patients, we can't get them into treatment anywhere.
Yeah. We did, with our counselor in the ER, we ended up sending people over very quickly, you know, sort of a rapid access kind of thing. So there were times when they would come in and they'd call us and we'd say, look, they don't have to be admitted to the hospital. Let's just get a bed over at Gosnold. And we did that many times. In terms of patients that were there in withdrawal, we could let them finish their withdrawal over at the treatment center so they would get discharged from the hospital quicker. And so the hospital took a priority at the treatment center in terms of, you know, they got the beds sooner. So that was part of it, and that helped a lot.
Very helpful. I think we'll make this the last question, although if anyone has who's listening has additional questions, we can have Peg and Ray answer them either at the very end, have a more general discussion with Nancy and after she presents, or we can have them get back to and send back email comments and reactions for you. Just as a last question, what was the single biggest barrier to implementation that you experienced in your program, and what did you find as an effective strategy for combating that barrier? Ask a big one.
I think.
Why is this so hard?
I think the attitudinal thing on it. I mean, I don't know what Peggy thinks, but I think the negative perceptions that the nurses had, and how little change there was with that, simply doing training seminars in an education room at the hospital. And I think that, and maybe some reluctance they had to using the medications more aggressively. The overcoming thing on the attitude piece was bringing them over here, bringing them over to the addiction unit, sticking them in here, and I mean, you can come in this place and you'd have trouble with most of the patients telling the difference between the patients and the staff. The patients are dressed, they're going to groups after the first few days, and so I think that was the most surprising thing, and I think it really knocked out a lot of their resistance.
And I had to do a lot of modeling. You know, at first when I would bring up that I was going to see a patient, they'd say, oh, go ahead. And then after a while, when they saw things working and they saw someone who was interested in alcohol dependence and chemical dependence, they became more interested. And so that was helpful, but a lot of it was just being there and having them watch and seeing someone else who was interested in it.
I was very impressed by your comments about changing our language, so that you were talking in terms of remission, return to acuity, improving functioning in remission, regression, reformulating a plan of care, changing medications and treatment plan, that these are patients with an illness, and you integrated your care into medical care rather than forcing the medical system to be different for addressing substance use.
Very important.
I'd like to now turn to Dr. Nancy Goler, who I think has done another incredibly successful program of integrating substance use and also referring back to what Ray was saying, behavioral health interventions into prenatal programs at Kaiser Permanente, Northern California. Nancy Goler is a practicing obstetrician gynecologist and is the regional medical director of the Early Start program at Northern California Kaiser Permanente. Dr. Goler graduated from Brown University and from the Medical College of Pennsylvania. She completed her residency in OBGYN at Kaiser Permanente and then joined the medical group in Fremont, California. She has published numerous papers on the Early Start program, and I just was flabbergasted at how good her program was and how I was totally unfamiliar with it. And I look forward to sharing with you the program that Nancy has developed, and also her thoughts on how a program can be, her program or program built off of her program can be adapted out of the somewhat special settings of Kaiser Permanente and into other practices. Nancy?
Thank you, Eric. And Ray and Peggy, your program is incredibly impressive. I love the work that you're doing out there, and it's a very hard act to follow. But I noticed as you were talking so many themes that were common between what you have been up against and what we have done here in Northern California. So just to be sure folks understand the size of the population we're talking about in Northern California, Kaiser Permanente here takes care of approximately 3.29 million members. We average about 35,000 births per year. in all our hospitals in Northern California. We have 42 facilities that provide OBGYN care with clinics as small as 3 to 4 providers and up to 15 to 20 providers. So we have a very large patient population, a very diverse set of types of clinics and situations where this program is delivered, and we are challenged, much in the way of the rest of the nation, of making sure patients are getting to the right place at the right time. But the things that just rung so true that I was hearing was this idea of meeting the patients where they're at. I mean, physically going to them in their hospitals, not waiting for them to show up later, or in the case of early start, which I'll be describing in just a moment, meeting them in the clinic where they're getting their prenatal care. The other thing was just dealing with the attitudes and beliefs of the medical profession and our own biases and the biases of our physician group sometimes, our nurses, our medical assistants, the people in the hospital, and realizing you have to work through all of that as well, and how important the use of language, being non-biased, less judgmental, more medical, and then, of course, the fact that you have these amazing outcomes. So it's not just doing the right thing, but you can just see these great outcomes. And the other part that just rung so true is this idea of how do we keep all the systems accessible, sort of the slipperiness that you described of the patients, how, when early start wasn't in Northern California, and we would identify somebody with substance use, and we'd send them over to chemical dependency, and somehow, even if it was just 2 doors away, they would slip away and wouldn't get to the next building or down the hall, and just how important it is to try and interlink our systems. And then the last thing, and Eric, you alluded to it as you introduced us, Early Start has been around since 1990. So we are not a young program. It took just in Northern California alone about 14 years to get this rolled out through all of Kaiser Permanente. Now, a lot of systems have been put into place since then that make it much easier, and now we're rolling out around Kaiser Permanentes across the nation, and we consult with community programs with different nations, with different states to transfer the program. But there's this difficulty in getting traction around this subject matter, even when you have amazing clinical and economic outcomes. And Early Start, which is a program designed for early intervention to stop the use of drugs, alcohol, and cigarettes in pregnancy, is a program that, unlike many programs, within 12 months of implementing, if you could implement all fully, within 12 months, you'll not only have improved outcomes for mothers and babies, it'll provide a net cost benefit. So, and the reason I can be so sure of this is because pregnancy is only 9 months long. So no matter what, once you reduce the morbidity in the hospital, especially of the neonates, and I'm going to show you the data to support this, you will have more than paid for the program, and you'll have a net cost savings. But like many programs, the savings are in the hospital because the bulk of savings are around the neonatal outcomes, but the cost for this program is in the ambulatory setting. And this is where our system, by which we're reimbursed around the nation, is a real barrier for how we get traction on these types of programs. At Kaiser Permanente, we're very lucky. Our costs, we're a prepaid medical program, and we're not for profit. And our costs are able to go back into the hiring, et cetera, and our anything we save in the hospital or save in the clinic goes back and forth between the two, between the medical group and the hospital. So we have a large benefit in how our pay structure is designed. The things that are key about Early Start is that it improves maternal and infant outcomes. It decreases the utilization of resources, largely the hospital resources, but I'll show you resources overall, and it leads to a net cost benefit. And what it does is it shifts the cost structure. So instead of paying for the preterm births and the negative birth outcomes, we will pay a lot less to prevent them. And it rung true as Ray was talking about trying to talk to the hospital administrators and thinking, why aren't you paying for this program? It should take nothing to seed the money to start for this program if you're truly decreasing ICU utilization by 40%. I mean, you've more than probably paid for the training and the materials for the hospital to deliver to its staff. And Early Start is that same idea, and we just can't afford any longer when you think of the costs that our neonates cost us as a nation to not move forward with a prevention for those costs. The innovation of Early Start came actually from a nurse practitioner who worked in the NICUs and was really very saddened by the number of children she was seeing born on drugs and alcohol, and particularly drugs at that time was the crack cocaine babies were very big. It was the late 80s. That was our biggest problem. Methamphetamines were a huge problem then. In Northern California now, we still deal with alcohol, tobacco, but our biggest problem is opiates, as it is across the nation. And her belief was that we needed to universally screen all women, and that's what we do in Northern California. We remove the judgment of guessing who's using and who's not using and the bias that's intrinsic in that. And so every woman, when they enter prenatal care, has a screening questionnaire that we've designed that talks about use both before and during pregnancy, as well as some questions that are largely cage questions. And then we do urine toxicology with consent on all our members. And the interesting thing about the net of the screening questionnaire is less than 2% of our positive urine toxicology has a negative screening questionnaire. And what that tells us is the most if not all, and I rarely use all or never, but I feel like it's all when I think of this very, very special patient population. These women want help. I've never met a woman who doesn't want a healthy baby, who's planning to keep her pregnancy. And she knows that what she's doing can harm her baby on some level. And so there's this ambivalence of being afraid to report, and yet at the same time allowing a toxicology screen. So what happens with the screening questionnaire is women generally will downplay their use, but the questionnaire has a very large net, so it will pick up even people who say they stopped drinking as soon as they found out they were pregnant. That's a positive screening questionnaire. Doesn't mean they're still using, doesn't mean they have a drug or alcohol problem or diagnosis of dependence, but it's someone that we want to talk to and assess and be sure of what's happening. In pregnancy, our goal is complete abstinence. So it's a really different goal, and it's a short-term goal. We do have people who relapse. If 80% of our smokers start smoking again, despite a lot of work done in the postpartum period. But our goal is to try to get everyone to stop during pregnancy. The second thing we do is we put a licensed mental health provider, and these are, with the exception of one psychologist, they're all LCSWs and MFTs. And we actually put them in the Department of OBGYN. They report through the structure of the OBGYN structure, so they report to the manager and chief of that department. They are a member of that department. They attend team meetings for that department. And their appointments with the member are linked to her appointments for prenatal care. So when the woman comes in, and she goes into the back and meets me as a doctor, she has an appointment to follow right there with the behaviorist, with the mental health specialist. And in this way, it removes some of the biggest barriers that can happen. For example, she's there with her mother-in-law and one of her other children, and her mother-in-law doesn't know that she uses or used or has a diagnosis of dependence. And she can just say, I'm going to go talk to my doctor alone, and then she can also sneak right in and talk to the early start specialist. It also removes that slipperiness of trying to get someone to go somewhere else to receive their services. So we're able to reduce all that. We also do not have a copay for the program. So we removed all of the financial barriers for this part of their care as well. Even though it is voluntary, much in the same way that you don't ask a patient, oh, would you like to see the GI specialist for your, irritable bowel or your diverticulosis or whatever, your blood in your stool and need a colonoscopy. We don't really ask in this one either. We don't ask, do you want to see the early start specialist? We say, oh, remember this questionnaire? It looks like you filled out a few things that have me concerned. I want you to talk to somebody who can give you some education about this the fact that you were drinking early in pregnancy, or the fact that you're using Vicodin for your pain, or whatever it is. And we kind of just take them down the hallway. So the woman really has to have a lot of resistance to not get down there, or we may have somebody out on a medical leave or a maternity leave, or something like that. And then we provide an enormous amount of education and educational materials. And I would say for the first 10 years, we were educating providers probably more than the patients themselves. We really don't, as physicians, receive the appropriate amount of education on substance use or chemical dependency as a group, and certainly not within obstetrics and gynecology. Those principles have stayed with us, and over the years, Early Start has won a lot of awards and recognition, both for our research and for quality. Some of these came with a fairly sizable financial reward, and what we did with that money is we invested in a database system. So we are connected with the Division of Research here in Northern California, and we're able, therefore, we have a very, very, very large database by which we can run research about the outcomes of our patients. And what I'd like to share, but before I go into the research, I want to share one last little piece. The OBGYNs are not great at screening or counseling around drug and alcohol use. And the standard of care from the American College of OBGYN is essentially you must screen all pregnant women. And if they're positive, you must refer them to treatment. And of course, that's where it falls apart, because the referral processes are highly varied across the nation. Sometimes there's no there, and sometimes the woman doesn't get there. So Early Start is actually at a higher caliber and a higher standard than the standard of my profession. But the Early Start specialist actually spends almost an hour doing a psychosocial assessment when they see her. So it's not so much a brief intervention, it's a very thorough intervention, and then as needed can link them into further programs. So we have an extensive addiction program. I sit on the Chiefs of Addiction in Northern California, even though I'm not an addictionologist. I sit in their committee to be sure our services are very integrated with them. We have a very strong relationship with psychiatry because of all of the dual diagnoses that we uncover. We have a very strong intimate partner violence program. So the specialist really helps this woman integrate into the other systems that are happening, and then continues, if a woman is at risk for using in pregnancy, continues to see her for shorter sessions throughout the entire pregnancy. We also use other modalities of care to provide this, such as follow-up telephone appointments, or even some video work appointments to be able to extend our net to reach women. Our research, we have a number of papers, but I'm really going to just share the outcome papers from 2008 and the one last year, just about a year ago in 2012, which is on a very specific cohort of patients, which first looked at the outcomes and then a very, very extensive cost-benefit analysis, which was very difficult to undertake because it is hard to find all the different costs and the codes, et cetera, but our Division of Research has access to our hospital-based codes and costs also, so we're able to do a net cost analysis. We looked at 49,261 female Kaiser Permanente members during the years of January of 99 to June of 2003, and they did all have to have a urine toxicology screening test and a birth at Kaiser Permanente, Northern California, in order to be in this cohort. And we had some other exclusion also. We actually did first pregnancies only, so that we wouldn't have a bias of history of preterm labor or other bad outcomes and have to keep bringing in more and more exclusion principles. We also only did it to singletons because twins or triplets have increased risks for preterm birth and things like that. But this was the basic cohort we've been looking at, and I would contend with looking at the research of substance use in pregnancy and SAMHSA and NIDA data that use hasn't decreased since these years. I don't believe that these outcomes, if I ran the data right now on our, over the last 4 years or 3.5 years, would be much different. But might even be worse because of the opiate problems that we're seeing. And our groups, it's a retrospective study because of the principles of our organization and the value that we have in this program, we just don't feel it would be ethical at all to run a study that disallowed women access to early start. So it's a retrospective study. But the women are divided into 4 groups, and the first group, screened positive, had that full 1-hour psychosocial assessment I referred to, and then continued to have follow-up with the early start specialist, at least 1 follow-up appointment. And that's the screened assessed follow-up group, SAF. The next group had the screening, and they also had an assessment, the full 1-hour psychosocial assessment. The early start specialist diagnosed them as needing further follow-up with early start. They also have referred them out to community resources like AA or to our chemical dependency program, but we co-see those at the same time. But for some reason, they didn't go back. And I don't have all those reasons, but there are multiple reasons. Sometimes they decline. Sometimes the early start specialist was out. Sometimes you have a clinic with 4 people. You don't necessarily have a full-time early start specialist there, and the member could only come on Tuesday, which was the specialist day off. All sorts of barriers, even in a program like ours, still exist. And then we had a very small group, 149 women who screened positive, including toxicology, who never got assessed or had follow-up. And then the last group screened negative. And we followed the maternal care from prenatal all the way through 1 year postpartum, and infant care from their birth hospitalization through 1 year pediatrics. And you had to maintain membership for at least 8 months in that first year to be eligible for the study. Now the S group, that group that was screened and didn't get in, I do want to be sure everyone understands that they weren't ignored. They actually received the standard of care. They were screened. Their provider discussed with them not using, concerns over the baby, concerns about their use. The provider repeatedly referred them to treatment, sometimes just down the hall, sometimes perhaps to a chemical dependency program. But they never got there. Despite having the program right there, they didn't get there. And sometimes because of no specialist there, sometimes they transferred their care around. They would start OB care in one place and keep moving between our different facilities, so we'd kind of lose them in the mix. And then a very small minority of patients would refuse the services completely. As I go through the next set of slides, I just want to, there's a pattern that you'll see over and over. One is that the group that got full early start services has no statistical difference in outcome than the controls. So we're able to get the outcomes around preterm birth and neonatal ventilation, which I'll be showing in a moment, to the same rate as the controls. And the screened group that screened positive but never got access to our program had statistically worse outcomes, not only than the C group, but then the group that got access to our program. And interestingly enough, even that 1-hour psychosocial intervention, just that assessment alone, gives good results. They have intermediary results, better than we had really thought they'd ever have. So if you look at the first slide here, this is the group, the SAF group right here, the full early start services. Even though it's at 8.1%, it's not statistically different than the controls here. But you can see that the rate of preterm birth, as defined as less than 37 weeks, is 2.1 times higher in the SAF group than the S group. And the same pattern goes on when you look at the rate of neonatal assisted ventilation. So these are babies that need to be on a breathing tube for a period of the start of their lives. And you can see that it's 2.2 times higher in the S group than the SAF and 3.1 times higher than in controls. And also, if you look at placental abruption, this is when the placenta separates early from the uterus in the pregnant mom, which is life-threatening both for mom and baby, often requiring blood transfusions from mom or baby and early deliveries. And what you can see here is no difference in the SAF than the controls, and the S group is 7 times more likely. And just so you all know, 0.9% is about the national average also. So for folks without risk factors. So our data is right in with what we would expect to see across the nation. And lastly, very sadly, is the rate of stillborns. You can see the SAF and control very low, and the stillborns were more than 14 times higher in the S group. And they, the impact perhaps of that is just hard to measure. The emotional impact, the loss of work, the toll that takes on the family, and just the devastation for everybody. So when When we looked at all of the costs, there was no doubt in my mind that the preterm birth costs would be where the greatest savings were. And we divided up these in different groups. And if you start looking at babies born at less than 32 weeks, you get a lot of babies that are born at less than 32 weeks for lots of reasons, congenital abnormalities, reasons we don't understand. We still don't understand all the reasons for preterm birth. And at less than 32 weeks, all babies are pretty sick and have to spend a fair amount of time in the hospital, especially your real little ones. And it's very hard, even though in that group we did have less babies born who were in the SAF group than the S group, their costs were not as far off from each other. They're a little higher in the S group because you're also dealing with neonatal abstinence syndrome and some other treatments, slightly longer lengths of stay, but they already have such a long length. But if you dive into this 33 to 36 week group, these babies were born, this group, 1.6 times higher in the S than the SAF group, but the cost per baby was really markedly different. The effects of having drugs on board at this age is pretty traumatic for these babies. And if we only looked at the cost savings for this group alone, it more than paid for the overall cost of the entire program. And just reducing this group of preterm births. And when we looked at all of the mean cost comparisons, what you can see is the maternal costs. The S group is slightly higher. It is statistically significant. It's not as dramatic because these outcomes are much more related to infant costs. And you can see the light blue line in the middle where the infant costs clearly are much higher per baby in the S group than the S SAF or controls. And then adding them together, that sort of mustardy color line, you can see the marked increase in costs. We also looked at our emergency services, and what we see is that the S group tends to use them more, 1.8 times higher than the SAF and 2.5 than the control. And I believe it's just because they're not as integrated into the system, they're not having as much support, so they end up using emergency services faster than using primary care. And lastly, we were actually very reassured by this slide. The increased use of mental health services in the mom is one of the goals of early starts. We want them to go over and be using psych and chemical dependency services. So this is the one place where we actually wanted those costs to be more similar and not different. So we thought that was a positive utilization. In Northern California, you can see here the different numbers that we use. I'll really just focus that the annual cost for the early start program is about $670,000, but the overall cost savings was over $23 million. And so when you subtracted one from the other, the annual net cost benefit was almost $6 million, and over the 3.5 years, and this 49,000 births came out to over $20 million of net cost savings. A lot of people wonder, it's taken a lot of years before we did the economic analysis for the general public. We had a business case from our early research, and that was how we worked with the health plan to fund the program. We made a lot of business cases. It's how we've worked to have it be a cost share program so that we could keep removing all the barriers, and the health plan who pays for the hospital services as well clearly saw the benefit to help. But really this program for me has been about improving maternal and infant morbidity and mortality. And I did a separate analysis just looking at this S group, and just to remind everybody, and this is less than 3% of our patients here, but also this is the standard of care in our communities for OBGYN that does not integrate substance use and chemical dependency use counseling and tobacco cessation and alcohol cessation use counseling into their prenatal programs. And what I look at with this S group is, if we could have gotten them there, what would have happened? Well, first, there would have been 15 more term babies, and there'd be 6 more babies that were able to breathe without a ventilator. 9 more women would not have gone through the very traumatic and difficult experience of a placental abruption, and 10 more babies would be alive. And so I pose the question in my papers is, and I make the statements that we can't afford to continue to provide the community standard of care when we so clearly have a standard of care for 3.3 million people, or 3.29 million members in Northern California Kaiser, who get a better standard of care by just integrating behavioral health with primary care. And there's just no doubt in my mind that the cost savings would more than pay for itself, without any doubt. So much like the program that we heard about in the beginning, we believe every woman deserves a non-punitive healthcare environment, just like every member in the hospital, so that she can have access to services and support to have an alcohol, tobacco, and drug-free pregnancy, allowing the delivery of a healthy baby. And at this point, we have a lot of materials to help transfer the program. Most of the time, the biggest barrier I come up with, and I've spoken to people at governor's offices and lots of communities, is this difficulty of the seed money and trying to work with the hospitals to recognize that the cost savings of quality will be so huge. But yet at the same time, hospitals are reimbursed for providing care. So we have slightly conflicting goals when it comes to the reimbursements of health care around substance abuse, and certainly in pregnancy. And I think at this point, I'm happy to open it up for questions. Hopefully I've given you enough broad strokes of the program so that people feel they understand what it is we're doing. Thank you.
Nancy, I'm as impressed in your presentation today as I was in reading the papers, maybe even more so because I can hear the passion and the concern that you have about women and their infants who are not getting access to care across the country. What is, as we've been working on this program for quite some time. You've been presenting on it. You've published research on it. What do you think needs to happen for us to be able to transfer this over into routine practice of care in other settings outside of the Kaiser system?
Yeah, that's an excellent question. I think a few things need to happen. One is the way in which we reimburse for health care needs to figure out how to reimburse for prevention. So without having the hospital feel that they're losing money and having this great fear that they're still going to have to provide the same level of care to these neonates and not be sure that they're going to get the same outcomes. And I think we need to continue to work, and I recently was out in Chicago with Nida and Samsa just looking at how do we help our government to understand reimbursement for integrating behavioral health and primary care and the benefits that affords us overall and in prevention. The second is using the stories of these women. There is no doubt in Northern California a lot of the resistance we had were providers. Many providers just not believing their patients used, or that their patients maybe would be lying to them about their use. And yet over and over and over we would find story after story after story where a woman wasn't telling the truth to her provider and the specialist would unfold something. And I think the more we can show that by being non-judgmental and non-biased, that and deliver these stories and have people realize that all women, no matter what their economic background is, their professional background, are at risk for using, that this is a disease, and continue to remove that stigma from this, I think are two of the biggest issues that need to happen.
Are you aware of any hospitals or other health systems that we now have all of these new sets of initials, ACOs and patient-centered medical homes? Are there other hospitals or settings that are implementing early start?
We've been contacted by different folks. We do have one last barrier that I realized I didn't mention. And for example, I believe it was Louisiana. If anyone's on the call from Louisiana, I apologize if I'm wrong. I have spoken to a number of different states. But we still have a lot of states that have mandated reporting and criminalization of use in pregnancy. So a lot of times when I'm consulted, that issue comes up. And so I've been consulted by some groups to ask how to do this. But to my knowledge, I don't think anyone's doing it. And a couple of places that are really strongly interested in doing this still have to deal with the fact that they're not recognizing this as a disease, and instead are recognizing this as some type of criminal or misdirected behavior. And as long as that's in place, it's going to be very hard to get women to be honest about their use because they're so afraid of losing their children. But I think we'll go there. I just don't think we're there yet.
One of the issues that we sometimes hear are the privacy concerns about talking about something as sensitive, and in some states with mandatory reporting. I'm not sure whether it's illegal, but it's can get your baby removed from you. But very private and sensitive topics of substance use, intimate partner violence, and the need on the other side of communication among health professionals who are providing care to a woman and her baby. How do you find navigating those issues of sensitive information and communication?
Yeah, that's a great question. Our specialists do at the very beginning give a pretty extensive informed consent about the program and the fact that the information will be shared with their OBGYN providers, and that this program is not, we are not a chemical dependency program. So we, if we do have a woman who actually needs treatment for her chemical dependency with buprenorphine, or we contract with methadone clinics, things like that, we send them out for that. So we are not an actual chemical dependency program. So we do make sure women understand that this information can be in their medical record, much like when I speak with them. We try very hard to educate them on the fact that this is important for their health care so that they don't run away. And it's pretty rare that somebody declines at that point. At this point, our specialists are actually able, the majority of the time, and it's very rare, to even get the written consent for when the woman does go to chemical dependency or psych, that the early start specialist can actually access and hear about that as well. I mean, we don't need to know all the details. As an OBGYN provider, I don't have to know every single detail that she's sharing with the early start specialist, but I certainly need to know a lot of it to provide her safe care. And so we really couch it all around her health and the health of her family, the health of her baby, and the fact that we can help, that she's not going to open this up and then just be left out there. And that, I think, has taken us a long way.
I appreciate that. If Ray or Peg are still on the line or able to come in, I'd like to kind of ask that same question because very clearly the Gosnold program is a substance use program. How have you managed this issue of communicating with the physicians and other healthcare providers about what happens both in the hospital and also when their patients are discharged over to your program?
When the patients, actually patients who get referred here for specialty care from the hospital, we really don't have a good feedback. Is that what you're talking about, the feedback loop to the doc?
Yeah.
We haven't done as well with that as we should, and in fact, partly because they're hospitalists, maybe. I mean, because their primaries don't follow them in the hospital here. The piece that we need to add is connecting the information back to the primary, and that happens in the few offices that we're in, but not as a general rule. We really haven't done as well as we ought to. Certainly Gosnold has, and I don't know about other places, in linking back to primary care, even for for patients, whether they come from the hospital or they don't come from the hospital. We get consents from the patients to do that at the time of their admission. I think our track record of actually doing it during their stay is spotty, and our post episodic treatment experience linkage is not where it needs to be. This whole business of seeing yourself as part of the mainstream of healthcare is not an easy thing to sell, even in the program, because we got 125 counselors. So it's a work in progress here.
Yeah, I appreciate that. I wanted to get back to Nancy with a question that, although my colleague Elizabeth Mumford, I don't believe, is on the call, when I told her about your program, she wanted to know whether you have tracked the impact of your program on maternal health after the baby is delivered. We tend to get very fixated, and this is her point, is that we tend often to get fixated on women as carriers of babies, and may not attend enough to the health of women postpartum, and wondered what your experience has been and whether you had data on that.
Yeah, that's another great question. The Early Start Specialists and the program can be accessed by women up to 1 year postpartum. It's kind of part of the program, we've only followed them out that 1 year for this research, looking at their utilization. And what we did see was there was, not any big difference in their utilization in healthcare as compared to the controls. We work a lot to try to knock down all of the different silos. So as I mentioned in the presentation, I was very glad to see that these women were using mental health services. But we didn't actually see a very big difference in their utilization of healthcare afterwards. I do think it's a very hard transition for this group of women to go from all this attention to now everything is focused on the baby. So we do allow them to continue with Early Start for a year, but mostly what we try to do is get them into the rest of our system so that they're getting their overall health care needs taken care of. We have not followed them out further than 1 year. We did glance at the babies out to 5 years, and after the first year, there's really very little difference in use and outcomes and utilization. I mean by use in the kids or outcomes. It was kind of surprising to us. We thought we would see more obvious developmental delay problems, but I think you just need even a larger cohort than the one we have, which seems unreal at 49,000, to start seeing those differences.
Something that impressed me there was, I think, a sub-discussion in both your presentation and Ray and Peg's presentation, was that the program initially, or has a strong substance use identification and intervention program within a healthcare medical setting. But you've also both talked about attending to other behavioral issues, maternal depression, intimate partner violence, tobacco use, and I wonder if both of you would talk a little bit about sort of your experience with being focusing either exclusively on substance use or advice about throwing a broader net.
Go ahead, Nancy.
Sure. I'm a big proponent of the broader net. I think that there's a lot more interplay that we don't understand in the neurobiology and psychology of substance dependence and other diseases, and I think that the interplay of mental health diseases, of depression and all of the anxiety, all of them, you pull all of those together, and then you have the disease of substance abuse or chemical dependency, and how does that alter the psychological diseases and vice versa, and then beyond that, medical diseases, which are also altered by these other conditions. And I think more and more research is showing that interplay and honestly validating for those of us in the field what I think we've always believed is that there's much more interplay than anyone has ever wanted to admit, and the continued silo of these entities of your chemical dependency programs, your psych programs, and then your medical programs, the more you keep them siloed, the less you're doing to help this patient. And the worse your outcomes will be in any one of those categories. So I really believe in the broader net.
Yeah, right on point.
Well, one of the points that I think you mentioned, Nancy, and clearly came across from what Ray and Peg were talking about, is that the behavioral counseling, your follow-up, the brief interventions, or brief interventions considered as being maybe 9 or 12 months of brief intervention, is integrated into the care setting. So it's not separate from the service that a woman comes in for prenatal care, or it's not separate from the consults that are called in for medically ill inpatients. Can you talk a little bit about that, how you made that happen, and advice for others who are implementing or trying to implement integrated programs?
Yeah, I think that the co-location of a behaviorist in primary care is going to be essential for us to be successful as providers in medicine, whether that's a walk-in clinic, internal medicine, family medicine, OBGYN care. And so I think that what seems like such a obvious innovation was so outside the norm, especially back in 1990, was really brilliant and has created a huge amount of success for our program by having the behaviors integrated right there. I'm sorry, Eric, as I started to answer, I blanked on the other part of your question. In terms of other programs doing it, so we do in the paper, it speaks to a model very delicately. You know, there's a limited number of words when you go to publish. We have an analysis about how many specialists you need based on usage in your community or suspected usage and delivery rates, et cetera. And we essentially talk about one full-time behaviorist to support about 1,800 births per year. And that's a rough sketch model of what we do. And the hard part becomes, how do you co-locate a behaviorist if you're not doing that many, or if you have multiple clinics all around one hospital, and how are you going to possibly be able to get this one person, you know, to 5 different settings and all sorts of things? And I think modern technology is the answer for something like Early Start, and it's one of the reasons why the paper, I think, is so timely. As more and more secure types of ways to communicate continue to be developed, so video appointments that are medically secure, or telephone appointments that are secure, I think you can deliver without always having face-to-face sessions this type of intervention. There's no doubt that face-to-face makes an enormous difference. I'm not sure an assessment by phone would go over very well. The lack of being able to see the body language, the facial expressions, I think really would limit the success of any behaviorist with this very high-risk group of women that have a lot of, ambivalence and complication around their disease process. But if you can bring other modalities by which people can see each other, I think you're going to change how we can deliver health care. And when you look at modern technology, that's what it's doing. And on top of it, the generation coming up behind me and my peers, they're so comfortable with using these other modalities, and it feels so natural to them that it's actually the specialists that I think and the behaviorists that will have more trouble getting comfortable with it because they're not in that generation. So we do have models by which you can transfer this program and understand different ways of reaching members, even if you don't have that large a patient population in one location.
Well, that begs for me with a follow-up question of, can you make those materials available?
I can't make them available. I can on a one-on-one type of basis.
Okay,
So
terrific.
I would need to deal with that separately.
Okay, terrific. Well, I do have a question that came in from Kate Strasser. She asked what the American College of OBGYNs, do they have a position on this kind of integrated care?
They've never put out a position statement to my knowledge, but they've been incredibly supportive of our program, and that's the Green Journal, which is the Journal of Obstetrics and Gynecology, is the journal from ACOG, and they're the ones who published our last paper. They've been very supportive. We also, the 2008 paper actually says, and the title was accepted as a new standard of care. So we've been very well received, and I believe they're incredibly supportive when I've spoken with anyone from there, but I don't think they have a position statement out per se.
Okay, terrific. Well, I appreciate that. Any last comments before I wrap up this call from you, Nancy, or from Ray?
No, I'm good. I enjoyed that very much, Nancy. Great job. Keep up the good work.
And I echo that with the work that you're doing. I really encourage folks who are listening, especially people who work on the hospital sides, to recognize the incredible rewards we would all have if we could get more of this work done before people get to the hospital, but when they do get into hospitals, to be sure they're supported fully with this work. So thank you very much for the opportunity.
Well, thanks to both of you. One of the things that just sort of struck me is it is that these kinds of really terrific examples of integrating care is finally moving back to the way that people actually are, which is that people are complex and they have multiple conditions, and they really don't want to go to separate places to get their care. And that both of you have just terrific examples of how to meet people where they are and to use respectful and helpful systems to support their recovery and their health. So I think this is really terrific examples. All of these, the presentation, as I mentioned earlier, has already been posted. The PowerPoints have been posted at the hospitalsbert.webs.com, and the audio recording will also be posted there. Also, if you go under the webinars button, you will find webinars and PowerPoint presentations on the following topics: the business case for Hospital SBIRT, implementing screening brief intervention in emergency departments, implementing the Joint Commission inpatient SBIRT measures, implementing SBIRT in trauma and other inpatient settings, reimbursement and coding for SBIRT in 2 parts, and a health professional's guide to SBIRT skills in I think 3 parts. So look forward to any additional comments or questions you have. At the conclusion of this call, or you will be receiving either immediately or shortly afterwards an email which asks for your experience of the information that you received, basically the sort of the usual satisfaction, and did you find it useful, and really would appreciate if you would fill it out and send it back to us. It helps us do better. Next month at this time, I don't have the date on with me right now, but you will see the announcement. We will have another webinar. This one we have online Tom McClellan, who will be talking about a Temple University Hospital discharge program that he has developed for SBIRT. Thank you very much, and I want to thank again our presenters who just did a fabulous job and are running amazing programs. We look forward to hearing more from you all in the future and working with you in the future. So thank you, everyone, and thanks for a really, really stimulating webinar.
Thanks, Eric.
Thank you, Eric.